So a brief introduction for Dr. Farhat. Dr. Farhat went to medical school and residency at American University of Beirut in Lebanon, and that was followed by a fellowship in pediatric urology at the University of Toronto, the Hospital for Sick Kids in Toronto. He was there for nearly 20 years and then joined us a few years ago as chief of the Division of Pediatric Urology here at UW, where he's now a professor in the CHS track. And certainly he's recognized at the national level for his interest in education and research, as he was recently elected to serve as the Education Research Chair of the American Association of Pediatric Urologists. So as you can see, his title for his Grand Rounds lecture today. And without further ado, turn it over to Dr. Farhat.
So I don't have a disclosure, but maybe one just to make sure that all the adult urologists will just bear with me, because this is most probably the dry subject for them on a Wednesday morning. Resident most probably also may not like this topic in general, because it's not a surgical topic, but it constitutes a lot of our practice on a regular basis. So within the next 40 minutes or so, I will be talking about bladder bowel dysfunction. It might be a personal journey and the way we actually get to learn about this entity, because if you look at the old versions of or old editions of Campbell's, you may not find that chapter. And most recently, this is becoming a core concept in pediatric urology practice. So I'm going to talk about the pathophysiology, the way I see it in terms of toilet training, and how the toilet training and the diaper industry had impacted toilet training in the industrialized world, and socioeconomical and cultural background for this. I will focus a lot of constipation. Understandably, I believe constipation is possibly the reason why we have sometimes bladder dysfunction. I will talk about questionnaires and how we diagnose patients with voiding dysfunction or bladder bowel dysfunction, and then finish by talking about the treatment. And the last 5 minutes of my lecture will be specifically to talk about what bladder bowel dysfunction had impacted our subspecialty and how I see it over the next maybe 10 to 15 years. For those who have kids, I can assure you that you always celebrate multiple things in your kids' life, but the most important part of that is when they become toilet trained, because I believe this is one chore less to do, changing diapers. And obviously, as a parent myself, even I know that when things are going well, we know things are going well, but once we start having some wedding accidents or any issues with bowel or bladder, then you know that's like a black box, and you open the black box and you realize that there is a lot of things you did not aware or were not aware about in your kids' bladder bowel function. Residents need to remember the sequence of maturation for the bladder and bowel. It's usually first at nighttime fecal continence, second is daytime fecal continence, and last is the nighttime urinary continence. You need to really recall at all times the bladder and the bowel have an eternal relationship. I am a believer, again, as I keep on always on saying, that the bowel has a huge impact on the bladder, but not vice versa. And as you practice more, you will realize that a lot of people may actually come for advice on how you can manage those two organs every now and then. Like any other organ, by the way, we know that the fetal and the early developmental milestones are key for normal function. And for that reason, I think any pathology that will impact bladder development in the fetal life may have a huge impact later on the toilet training. For instance, we know in pediatric urology that posterior urethral valves and patients with exstrophy, classical bladder exstrophy, may never attain toilet training. That's because the bladder had not been cycling the way it should be cycling in the fetal life. Functionally, also, we know that patients with spina bifida or cerebral palsy or anorectal malformation also do have a bit of a change in their toilet training habits, and they may never attain it, or they may attain it a bit later in life. The childhood, on the other hand, is more important to some extent because it's subjected to socioeconomical and cultural backgrounds. And what I mean by this is that if you really do a literature review, you will find that toilet training had been an interesting topic since the 50s, because we know, for instance, in certain nations, toilet training is much more attainable at the age of 6 months, for instance, in Kenya. In Vietnam and in parts of China, there are certain grandparents or parents even who would do voice activation for the bladder or bowel function. And in China, for instance, there is a split pants that are quite common in rural area where kids will be able to attain toilet training as early as they want, just because there are no social boundaries and they can just go wherever they feel like. One of the interesting topics that I like to relate to toilet training is the fact that socioeconomical and economical conditions can have an impact on the toilet training phase. And that's why in Turkey, there are a few studies that came out showing that training is dependent on the income of the parents. And again, I'm not going to take you through the sociological background or history in the US or in Canada. But if you really focus on this graph there, if you see my mouse there, the X here is indicating the time when disposable diapers were invented. And then in 1962, Tom Barry Brazelton, who was a pediatrician and also a pediatric psychiatrist, came out and said, you should wait for the readiness of the kids to be able to get them to be toilet trained. And this graph indicates, the white line indicates that the start age of toilet training in the US started to increase since then. And attaining toilet training, which is the black line here, became even longer and longer. While on the other hand, half of the population on the globe continued to have their toilet training at the same time. And that's again because toilet training and the industry of diaper is very much related. For instance, in 1961, it had been reported that 10% of kids are in diapers. On the other hand, in 1997, it's about 78% are in diapers. Whether this have an impact on toilet training / bladder bowel dysfunction, I mean, I'm happy to discuss that further if you wish, but unfortunately, this is not going to be the topic of today because I think we want to talk about clinical entity, not sociological entity. Tom Brazelton, or Barry Brazelton, used to be the one to say that men who change diapers will change the world. And obviously, he did not know that that had a huge impact later on bladder bowel dysfunction or bladder bowel function in general. Barry Brazelton, by the way, was the chairman of Pampers for Parents organizations, and he was basically a stockholder of Procter & Gamble. And again, there was a lot of economical revenue back from the industry of the diapers. And again, I think it's very important for us to just make sure that this topic brought up today is not to really point fingers, but just the fact that evolution and socioeconomical changes may have an impact on our behavior the same way that, technological advances with iPhones, iPads, and all of that have been also being brought up as a change in our behavior or sociological changes. Incontinence is a social burden, not only for pediatric population, it's actually even for adults more. And that's why if you just browse the internet, you will find a lot of things that parents will seek support and help when they have their kids incontinent. And again, there's a lot of business background behind all of those advertisements and all of those recommendations. For instance, if you look at very common websites talking about how you can help your kids to be less incontinent or less wetting, experiencing less wetting accidents, you will see that they are advised to change diapers very frequently. They are advised to take probiotic yogurt and drink a lot of cranberry juice. And the reason why this is an important topic for pediatric urology is, unfortunately, any child or any pediatric patient who starts developing bladder issues is always and most of the time labeled as having possible urinary tract infection. And that's why they end up being on our quota there in our clinic, seeing them to figure out how we can help them out. For those who like to watch TV still, whenever you come across a Pampers commercial, please, I would advise you to just watch how they are basically advising parents to use Pampers, because this will stop the kids from waking up at 3 a.m. for a change of diaper, which by itself, by the way, is known to be a phenomenon for adequate bladder brain maturation. And for that reason, I think that the industry or the diaper industry had quite a huge impact on toilet training and may have an impact on bladder bowel dysfunction. I'm going to change gears now and talk about constipation. I mean, this is again not the perfect topic for a Wednesday morning, but I guess you need to really understand that constipation is one of those social taboos. People don't like to talk about a lot of things we do in pediatric urology, whether it's genital anomalies, constipation, or wetting accidents. And I came across this paper when I was actually helping somebody from Israel to put his thesis on relationship between constipation and the urinary tract system. And it was quite impressive to know that industrialized carbohydrates, as they call them in the nutrition industry, is well known to be a cause of constipation, which, and according to that paper, which is a historical paper, is calling it as disease of the diseases. Constipation, unfortunately, in the pediatric population can be a bit tough sometimes to diagnose, and this is what this is why here we have the Rome criteria for functional constipation. There is a long list of the different ways of diagnosing constipation. And the interesting part for us when we are talking to the parents about constipation is the fact that the kids will just be there and the parents will look at him and say, don't you poop every week? Don't you poop every day? Because the parents really would not know about this. Understandably, they have other things to take care of. And this Rome classification is even much more tougher to basically follow in the clinic because, as you can see, there are multiple different items that you need to follow on. I like this fact that there is also an economical relationship between constipation and bladder issues, because this is here the Australian government is basically requesting from the adults to basically follow some recommendations on avoiding constipation. Obviously, this is becoming a national issue, maybe sometime somewhere in Australia, but the squatting and the change in the way toilet seats are being made now have an impact also on constipation. Again, this is really quite an interesting topic for the people who are going to be delving more into this. But the reason why we are, again, the one to take all the burden from constipation in the children is because kids are known to have constipation. I think it's reported in the literature that 10% of kids between the age of 5 and 8 will fulfill the definition of functional constipation. I personally think that at least in Madison, the kids I have seen in my clinic, 80% of are constipated. Most of them are on stool softener. And about 2 to 7% of the kids in the US have encopresis or fecal soiling. And I think that's really physiological because boys are the one who void while standing, and that's why boys have higher chance of encopresis. This is important for the residents also to realize that encopresis is more common in boys than girls. It's customary to think that it's every child or adult should have a bowel movement 1 to 3 times a week. And I don't think it's sometimes easy to convince the parents that their kids are not having constipation. For that reason, if you look at the ways to avoid constipation, you could see that the 3 main approaches or natural habits is to drink a lot of fluids, is to make sure that you eat a lot of vegetables, and to be active. And you can only imagine at this time and age, obsession and addiction to electronics and the kids being interested in not going to the washroom at all will make them hold stool even much more common, more before than the introduction of electronics and stuff like iPad or phones and all of the other things that the kids are being busy to. So this is another reason why I think our advances in technology had made possibly an impact on the way kids behave when it comes to bladder and bowel. I mean, the residents need to understand that constipation and bowel and bladder function, will cause bladder sphincteric dysfunction. And what I mean by this is that naturally, all of us, when we have the urge to have a bowel movement or a bladder contraction, it's natural to just contract the sphincter, because if it's not socially acceptable, you may not go. On the other hand, kids, unfortunately, because they are severely constipated, or they have the ability to postpone their bladder contraction and not to go void and pee, they end up having a fixed external sphincter contraction. And that by itself will show up on a VCG, for instance, as a spinning top deformity. And that's what we think is that the thickening of the bladder is together to tightening of the sphincter. But those are the two behaviors that I think sometimes can be very much elucidating bladder bowel dysfunction. It's the holding maneuver or curtsying. And that's because the kids are trying to really stop the bladder from contracting and stop themselves from wetting themselves, or even to have a bowel movement. We do believe actually that sometimes when you have severe constipation, it may impact even the trigone. And that's what we found in the thesis that we worked on 12 years ago almost, that it may actually induce reflux and it may cause even hydronephrosis. Because if you do a cystoscopy, and a lot of the time with the residents, I would show them on cystoscopy with the severely constipated kids, you can see the trigone elevated, and that might cause a complete change in the bladder function. The bladder bowel dysfunction presentation is most of the time wetting accidents, or frequency or urgency. And again, I want to emphasize to everyone listening to this possibly boring subject that the diagnosis of UTI always come as the first reason for those patients having those accidents. Encopresis, abdominal pain, vague pelvic symptom could be also very common. Urinary tract infection, reflux, hydronephrosis, and even, unfortunately, renal failure may happen. The old editions of Campbell's used to talk about severe bladder bowel dysfunction as the Hinman syndrome, or non-neurogenic and neurogenic bladder, because those patients used to look like having a severe reflux, they have severe hydronephrosis, but there was no abnormality whatsoever in the spinal cord. And those were the patients who we used to see at the end of their clinical deterioration with renal failure. It's always important to really get a good history. Holding urine for a long time, I call it the pee dance, because that might attract the kids to be more engaged in the conversation. Most of the time, the kids will void small amounts every now and then, but the key is to make sure that you can get a bit of history on their neuropsychiatric stage. And what I mean by this is that a lot of the kids, the minute they walk into the clinic, we could tell possibly they have ADHD or they may have autism. And unfortunately, parents do not understand that those neuropsychiatric conditions may delay bladder bowel function or toilet training. And that's why it's another burden on us that we are not only pediatric urologists, we have to be sometimes psychologists to understand what's going on at home. I want to emphasize again and again that this is the presentation of bladder bowel dysfunction. This is why it's no man's land. I know that a lot of pediatricians get engaged into the care for those patients, pediatric nephrologists. I'm not sure if we got them to be on this link today to attend this grand round, but I know that nephrology group, and we always talk about the fact that we're having a lot of those patients who we need to figure out how to help them out. The issue for pediatric urology is that BBD is most of the time non-surgical, and majority of the time we just see them on multiple occasions. Some of them will improve, some of them unfortunately do not improve, and parents become very frustrated. It's a highly morbid condition. If again you want to dwell on the literature behind that, it had been shown that most of those kids will undergo multiple imaging prior to being diagnosed with bladder bowel dysfunction. The imaging could include even CT scans sometimes, or could include VCUG multiple times, because they are looking for a reflux that's causing all of those sweating accidents. It is highly morbid from a psychosocial aspect, and also disruptive to the family. I mean, if you really get a heart-to-heart conversation with the parents, most of the time they're really frustrated because it's a new burden on them economically, because they have to pay again for diapers and pull-ups. Pull-ups, by the way, is only a diaper that had been invented in 1989, and I wish that I would have the time to really relate this industry to the fact that bladder bowel dysfunction have become much more common since the 90s. And at that time, the pull-ups have been allowing the kids to basically wet themselves, but they are feeling much better because they don't need anybody to change their diapers for them. Bladder bowel dysfunction is a new term. And again, as I said, in the Campbell's for the residents, you may find a lot of different terminology. The ICCS, or the International Children's Continence Society, came up with two categories to assess the bladder between the storage and the voiding. I mean, really, the different list there is not indicative of anything but bladder bowel dysfunction. That's why I put it at the overhead as subgroup. But you need to ask specific questions. And again, I have to dwell more on the dysfunctional environment. This is a picture from a paper in the 80s, if I'm not wrong. And at that time, they were basically talking about what is first. Is it the psychosocial problems causing voiding dysfunction, or the voiding dysfunction and the urinary tract infection causing psychosocial problems? There's a lot of data on nocturnal enuresis, by the way, and psychosocial problems. There's a lot of data now showing that nocturnal enuresis is secondary to daytime inappropriate bladder function, but there's not a lot of data that is common in the pediatric literature talking about the fact that dysfunctional environments are possibly the most common reason for bladder bowel dysfunction. This is here data that we collected in Toronto on hundreds of patients where we surveyed them with neuropsychiatric questionnaires, and we found that quarter of them almost do have neuropsychiatric conditions, whether it's overachievers, kids who have been very obsessive compulsive, a lot of parental issues, divorce rate, anxiety disorders, and sometimes sexually abused children, unfortunately, may manifest as having bladder bowel dysfunction. So you can only see that the history is such an intricate part of the workup for those patients. And again, I think I'm wondering if at one point fellows in pediatric urology will need to do some rotations on psychology just to understand how to approach those patients and population. By no means I want the residents to walk away today thinking that every wet kid is avoiding dysfunction or a bladder bowel dysfunction. Your physical exam and the history you take is going to be quite important. And this is why I really urge you to always make sure that you rule out some of the other rare but yet possible diagnoses, such as ectopic ureter or female epispadias, which I have seen in my practice, obviously, when patients have been referred because of incontinence, but unfortunately, nobody have examined the skid. And spina bifida occulta is something that you really need to keep in mind. Not to the extent that every bladder bowel dysfunction should have an MRI of their spine, but at least you need to make a judgment on when you want to be interfering or doing more imaging for this population. The way we diagnose bladder bowel dysfunction is, aside from history and physical exam, we have tons of questionnaires. And I'm really not sure that we created those questionnaires to make sure that we have the data that we request, because the parents are really reluctant to or unable to share their observations at home. This is the DVSS. This is the Dysfunctional Voiding Symptom Score that we came up with in 2000. That's 20 years ago, God. This questionnaire was really the first questionnaire to address voiding dysfunction, and that's why it's called the Dysfunctional Voiding Symptom Score. We avoided calling it VD because venereal diseases at that time was something that we didn't want to really associate with. And DVSS is very much similar to the IPSS. We basically looked at the International Prostate Symptom Score and somehow emulated it or copied part of it. And we talked about the quantity of wetting accidents, the frequency of wetting accidents, the relationship to bowel movement, and the P-dance was mentioned there. And also we brought in psychosocial question. This was only 10 questionnaire. And I would say that this was helpful not only to diagnose patients or children with voiding dysfunction and bladder bowel dysfunction, it also allowed us to see if they are improving over time. So the symptom score used to drop when they have improvement. And we also found out that in 2002, if I'm not wrong, we published a paper showing that if you have kids with reflux, their symptom score will improve if their reflux go away. That was at the time when we used to do VCUGs for them, and we knew about the relationship between bladder bowel dysfunction and reflux. This questionnaire had been translated into almost 6 other languages. And this is possibly the one paper out of all my publications that had been cited immensely in the literature. The second questionnaire is, the purpose of it is to again remind the parents that having a bowel movement does not mean that your kid is not constipated. So we give them this a piece of paper with the hope that they are going to really relate the type of stool that their kids have and make sure that it's type 3 or 4. And you can only imagine it is a lot of burden on the family to figure out how they want to do this on a 5-year-old or older. And they want to make sure that every bowel movement they need to record this for us, just for the purpose of convincing them that their kid does have constipation. On the left-hand side here, we have the voiding diary. I tell everyone in the clinic that the voiding diary is an indicator of parental commitment. If the family comes back with a voiding diary that they usually fill inappropriately, that tells me that the family is going to be really tough to get them to be engaged in the treatment we want to offer their kid. And I cannot emphasize the importance of having allied healthcare providers who could possibly indicate or share with the family the importance of filling this voiding diary appropriately. That's not done. I think we're going to talk a bit about our approach at AFCH in the division and how we're increasing the yield of those questionnaires. Strength and difficulties questionnaire is possibly the one questionnaire that could unmask any neuropsychiatric diagnosis. It's a long questionnaire. You have to get the parents to really be committed to fill it. And sometimes you have to introduce the parents to the concept of why you want them to do it. And that's because, you ask questions, how is he doing at school? And now with the stay-home order, I don't think you can ask those questions. So you really need to rely on parents to come in and volunteer some of the information that's important for us to rule out any other pathology. The majority of the kids with bladder bowel dysfunction, by the way, need bladder and bowel retraining. It's called urotherapy because the ICCS called it a urotherapy as a non-standardized term referring to non-surgical and non-pharmacological treatment. That's a good news for the parents. I always tell them, if you can get your kids to be retrained, that means that most probably the kids will actually do much better. Much better with wetting accidents, much better with constipation. And again, the commitment from parents is needed. Children with refractory conditions are the kids who may need further investigation and other treatment options. In Netherlands, by the way, for instance, patients who will go on urotherapy get admitted to the hospital for almost 7 to 10 days. And this is why urotherapy in certain places is much more successful than it is in the US, or at least in North American continent, because we really don't do the same things. We don't admit patients, and we would like the parents to be involved in the care of their kids at home. The overarching steps are simple, natural habits, I call them. More intake of fluids, avoid certain fluids such as juice and caffeine, more output, going to the washroom on a regular basis, double voiding, monitor bowel movements, and body positions. I mean, those are the things that you need to possibly dwell on more with the family in terms of, are they able to take, or are the kids taking their underwear and their pants below their knees when they are voiding? If they have high BMI, they may be voiding into their a female may be voiding into the vagina. Are they resting their feet on a flat surface? Are they able to coordinate the muscle between the bladder and the bowel? That's is where biofeedback may be valuable in certain patients. I am a believer that COVID actually, with the silver lining of staying home, have allowed some kids to be watched much closer by their parents. And I just heard from UW Media outlet yesterday that they are interested to follow up on this statement I made to one of the people in the hospital. So I'm hoping that we will be able to really get people to understand that staying home could be a good advantage for them to watch their kids' habits much better than before. There is a need for time and commitment. Urotherapy takes a lot of time, unfortunately. You need to educate the parents and you need to reassure them. And you need to maintain and follow up on this behavior, or at least with the family. And it all depends on the family dynamics. I mean, divorcees, for instance, end up having their kids separated or with each one of them on a different occasion. And that's why you may need to train both parents to know how to take care of those issues. And not all of the parents will have the same interest. So you can only imagine, I mean, I don't want to be sounding like I'm whining about it, but imagine as a pediatric urologist, we have to not only take care of the patient himself, but we also have to take care of other psychosocial issues that might be revolving around the problem that the kid is in the clinic for. So this is why I truly do believe that health psychologists and social workers are beyond important for this entity. And those are the two allied healthcare providers that I believe would be able to really be at the forefront assisting us in this population. Urotherapy outcome, by the way, just to give a sense to the residents about its success, it's successful in 2/3 of the time. And the remaining 1/3, maybe you may need to be involved in, or you may need to ask for more studies. Urine analysis, every now and then you get this anecdotal case of a kid who is diabetic or found to be diabetic, has large urine output, and that's why they are wetting themselves. Ultrasound, sometimes it's done for the purpose of reassuring parents. Urodynamics is rarely indicated, and when it's indicated to rule out other problems such as tethered cord or spina bifida occulta. And again, you need to check on family dynamics and their commitment. And those are the things that sometimes may need to be addressed with another visit to the clinic or another telemedicine and ask why there is no improvement. You know, I find sometimes that if I go through the habits the kids are going through, the posture they do, the psychological background behind what they are going through, and psychosocial issues may help. This is a VCUG where the contrast is going into the vagina because the girl was basically contracting the sphincter and not allowing all the urine to go out. And another condition could be such as labial adhesions. So not every time they don't improve, you need to jump on to do multiple other studies. It's important to really get another history, another physical exam, make sure that you're not missing on any of the possible common reasons for that to be happening. The treatment for bladder bowel dysfunction, and I put them in terms of priority, first and most important is constipation management. I do think that if you treat constipation adequately and you do give clean out for those kids, you may improve their bladder function to no end. The behavioral modification that we suggest between time voiding and diaries and fluids and all of that is really dependent on the parents' commitment and the child commitment and their neuropsychiatric conditions. Infection control, I'm not going to really underestimate the value of antibiotics every now and then because, yes, indeed, some patients with bladder bowel dysfunction may have urinary tract infection, and those patients will need to be on prophylaxis. But otherwise, you may not need to put those kids on prophylaxis. Biofeedback therapy is really helpful, but it's not the first treatment option. It's possibly the second or the third. Every now and then, we have certain kids that we give them pharmacological management. This is the time when I believe pediatric urology skills and knowledge can come into the picture. Once you have failed urotherapy, you have failed biofeedback, well, this is where we can come into the picture and figure out, do we need to give anticholinergics? We do give a lot of alpha blockers to our kids, by the way. And Botox had been shown to be valuable or helpful in patients with external sphincter dysynergia. That might help the sphincter to just become completely atonic and allow the kids to just have ability to void with no sphincteric dysfunction. InterStim had been reported to be a very successful treatment option. And obviously the PTNS or posterior tibial nerve stimulation is also another treatment option that we are trying to investigate here at AFCH for the patients who are not recovering as well as we would like them to. Unfortunately, some patients will end up having to be on clean intermittent catheterization. Nephrology and urology have few patients of those. We have to possibly do sometimes Mitrofanov. For the kids who have sensate urethra, it will be very difficult to do CIC, and they are not really compliant. So you can only imagine the spectrum of treatment ranges from urotherapy all the way to very aggressive treatment. I have to give credits to the nursing staff and the urology division for what they have put together as bladder bowel dysfunction pathway. Sarah Truscott and Jenica with Jen Bennett at the East Clinic had started what we call as bladder bowel dysfunction pathway. Every institution, by the way, has a way to deal with their bladder bowel dysfunction population because, again, it's a burden on the system. It takes away a lot of our clinical time from surgical patients. And this had been really a good way of approaching patients and triaging patients and figuring out what do we need to do for them and when do we need to see them. I was ecstatic to know the other day that we have certain patients after going through the teaching by Sarah Truscott at East Clinic. Parents are basically not needing to come, not that they are not wanting to come. They are not needing to come possibly because they are getting the idea about how they can help their kids. So hopefully within a year from now, we'll be able to get this much more mature and be able to capture better, more patients. Maybe another 6 to 7 minutes on impact. And what I mean by impact is not on the child or parents or the system. I mean, I talk about that a lot. And I think I would like to just talk a bit about the impact on the pediatric urology. When I was chairing a committee at the Royal College of Physicians and Surgeons in Canada to establish pediatric urology as a subspecialty in Canada, I came across this caricature there, and it's so interesting how pediatric urology as a new subspecialty is looked at as being betrayed by two other disciplines. And I really don't want to keep that in your brain as an image about how I see pediatric urology. I think we have come a long way since we started dealing with patients with only reflux. And the reason I say that is because pediatric urology really started in the 60s and 70s. And it really depended on abnormal anatomy means surgery. Some of those people there are still alive. And I can tell you that when I even read about pediatric urology as a junior resident, it was common for any hydronephrotic patient and any patient with reflux who is not improving will need surgery. And that's typically what happened in the 60s, 70s. And then later on in the 80s, it was possibly the age of separation, which means that pediatric urology became really a subspecialty. It was 80% of clinic visits will end up being in the operating room. Antenatal diagnosis was starting to evolve, and it was center-driven. And what I mean by center-driven is that every institution was known for something. For instance, at SickKids, we were known for three entities: pediatric kidney transplantation, posterior valve management, and exstrophy repair. And later on in the 90s, that's the time when I started my residency and moving on to become a pediatric urologist, then surgical cases started to drop off. Like, it was becoming much more common to see medical patients in the clinic. This is why pediatric urology is possibly the most medico-surgical entity I can imagine. Voiding dysfunction became bladder bowel dysfunction. Ambiguous genitalia started to be called differences of sexual differentiation. Laparoscopy for simple undistended testicle started to evolve into robotic. And exstrophy, when we used to repair it with 3 to 4 stages, it became a single stage high exstrophy repairs. So really, you can see that we have evolved immensely. But the foundations of pediatric urology practice are really, aside from hypospadias, are UTI, vesicoureteral reflux, and hydronephrosis. And I'm someone who believes that there is no primary vesicoureteral reflux. I think all reflux is secondary. We have learned a lot about the bladder physiology over the last 20 years. And I think posterior valve and spina bifida and the way we watch those kids with reflux taught us that we can also watch refluxing patients, such as reflux that's diagnosed after birth. These are the refluxing patients who never contracted the urinary tract infection, how we published data showing that they actually end up having the reflux go away when they are adequately toilet trained. And this was in 2001. So you can only imagine how much we learned from that time on. And those are the kind of papers that come out now. And there's not a single paper that talks about recurrent urinary tract infection, renal scarring that will not bring BBD into the picture, or talking about the voiding symptom score, whether it's the one that we came up with in Toronto or any other symptom score and its relation to reflux and bladder bowel dysfunction. And I can't really but say the one thing is that I think as urologists, we have spent a lot of time underestimating the value of the bladder in a way that I remember we used to call it the forgiving organ, till Tony Atalla spearheaded the research in the 2000 on creating a bladder or a tissue engineered bladder. And when I was doing some research in that area, I came across a lot of interesting findings that really tells me that the bladder, and should tell you as urologist, that the bladder is if it's put on a fast mode action, it's no different than the heart. It has a very intricate infrastructure, whether it's with its muscles, its collagen deposition, and even its blood vessels. And I think we possibly shot ourselves in the foot by giving it less of importance. And I think now in 2020, I do believe that the bladder has a lot of impact on almost everything we see in pediatric urology, for instance. Believe it or not, now we know that if you do an ultrasound and you see a lot of hydronephrosis, if the bladder is full, you may request another ultrasound just because you want to make sure that the hydronephrosis is not secondary to a full bladder. So in 2020, where we are is that we lost the kidney tumors, unfortunately. We don't get involved except if they want to be kind enough to ask us to go in and do some partial nephrectomies for them. We are not doing the great job with the treatment of patients with DST, or as we are trying to call them now, variations of sexual characteristics. We got pushed away from kidney transplants, or at least we're not doing kidney transplants, but we know now that kidney transplant, by the way, may fail if the lower urinary tract in children is not appropriately assessed. So on the left-hand side here is the core practice we have in bladder bowel dysfunction is possibly 40% of our practice. And how can we make this still be part of our care, but at the same multidisciplinary care is what my goal is as a chief and also as a member of the division. We do care for patients after circumcision, hypospadias, hydroceles, and hernia. MIS is going to stay. Obviously, robotic surgery is going to stay. Hopefully, we'll continue on taking care of patients with UPJ, and the few patients who need reflux surgery, will take care of them. And stones and prenatal care and complex care will continue to be part of pediatric urology. But how are we going to really take advantage of bladder bowel dysfunction and possibly offload some of those patients to the right people is going to be a task that's going to possibly be more difficult than I would like. We used to say take home messages. Now we're all at home. So stay home messages will be to really try to convince you that bladder bowel dysfunction is societal and partially economical more than anything else in my mind. BBD is associated with urinary tract infection, reflux, and neuropsychiatric conditions, but you should not underestimate the toilet training and its relationship to bladder bowel dysfunction. Most of the time, bladder bowel dysfunction management is behavioral, and by resetting the function of the bladder and the bowel. And yes, bladder bowel dysfunction, whether we like it or not, has changed the landscape of practice in pediatric urology. And I think we are now equipped with the knowledge to make sure that we are delivering the best care for those patients. But we still need a lot of support from allied healthcare providers, whether it's health psychologists or social workers. And I cannot emphasize this more because these are the people who would know the language on how to deal with neuropsychiatric conditions for this population. And I'm at 7:45. Thank you so much. And I'm happy to take any questions.